We will now begin with the third plenary session on interventional stroke medicine. To introduce the speakers is our moderator. He is a consultant of vascular and interventional neurology in St. Luke's Medical Center, Capital Medical Center, and East Avenue Medical Center. He is a residency training officer of the adult neurology in St. Luke's Medical Center and is the head of the stroke service in East Avenue Medical Center and head of the faculty relations in St. Luke's Medical Center, College of Medicine, William H. Quasha Memorial. He is currently the co-chair of the research committee of the Philippine Neurological Association. Ladies and gentlemen, let us all welcome our moderator, Dr. Dan Neftali Huangco.
So a pleasant morning to everyone, a pleasant morning to our esteemed colleagues, distinguished guests, and friends. Welcome to this plenary session for the PAVIN First Biennial Conference and Grand Launch. So this session, Interventional Stroke Medicine, will highlight breakthroughs, advanced strategies, and evolving practices in thrombectomy and neurovascular interventions, critical areas shaping the future of stroke care. On a personal note, I'm very happy we have this session today to present to you our small but slowly growing group of interventional neurologists. Our first speaker earned her Doctor of Medicine from the University of the East Ramon Magsaysay Memorial Medical Center. She completed her adult neurology residency at Quirino Memorial Medical Center and pursued interventional neurology in Indonesia. She further completed her fellowship in interventional neuroradiology in Zurich. We are honored to welcome Dr. Dianne K. Ferrer, who will deliver her lecture, Mechanical Thrombectomy, Past Breakthroughs, Present Practice, and Future Horizons. Our second speaker graduated magna cum laude from the University of Santo Tomas Faculty of Medicine and Surgery. She completed her residency in neurology and fellowship in stroke and cerebrovascular diseases at the UP Philippine General Hospital, followed by an advanced fellowship in stroke neurology and neurovascular intervention at the University of Toronto's Sunnybrook Health Sciences. Please welcome Dr. Clare Enriquez, who will present her lecture, Cracking the Posterior Circulation Code, Advanced Strategies for Complex Thrombectomy. Our third speaker has extensive international fellowship training in India, Japan, and Switzerland. She's an active consultant in multiple hospitals in Laguna. With a strong interest in research, she has published and presented internationally on stroke and neurovascular interventions. We are privileged to hear from Dr. Roselyn Pamatmat, who will discuss beyond the procedure, hemodynamic precision and neuroprotection after thrombectomy. As a reminder, throughout the lectures, a QR code will be flashed on the screens. We encourage all attendees to scan the code and send in your questions. This will be entertained during the open forum after all the lectures have been delivered. And now, to begin our session, may I call on our first speaker, Dr. Dianne K. Ferrer.
Good morning. I'm Dr. Dianne Ferrer, and I'm going to talk on mechanical thrombectomy, past breakthroughs, present practice, and future horizons. So this will be our objectives for this talk. So first off, we have to define what is mechanical thrombectomy. So it is synonymous, or it is also known as endovascular thrombectomy or emergency clot retrieval. It is a minimally invasive catheter-based procedure, and it aims to remove intracranial thrombus in LVO or large vessel occlusion. This is being performed by neurointerventionalists. Neurointerventionalists can be a neurologist, an endovascular surgeon, or an interventional neuroradiologist. So the goal is rapid perfusion, reperfusion to improve functional outcome. So this is an overview on how mechanical thrombectomy is being performed. So we create access by puncturing the groin or the wrist area, And we do insert catheter and wires through this access. We thread the wire and catheter until we reach the clot. And the removal of clot can be done by solely aspiration, or we can use the stent retriever, which is this mesh device that is used to retrieve the clot or to capture the clot. This can be done also in combination, which is stent retriever with aspiration, with or without the use of your balloon guide catheter. So what is a large vessel occlusion? So this is involves your intracranial arteries with luminal diameter of more than 2 millimeter. So meaning this includes your intracranial ICA, your basilar artery, your vertebral artery, M1 and A1 and P1 segments. So 24 to 38% of acute ischemic strokes are LVO. In the landmark large clinical trials, 46% involve A2 and P2 segments. 2/3 of LVOs occur in the anterior circulation, and 10% occur as tandem occlusion. It has the worst clinical outcomes of acute ischemic strokes. So this is your aspects. So this scoring system helps clinicians predict functional outcomes and symptomatic hemorrhage. So the perfect score is 10. Okay, so this is a review for the residents who are here today. So the perfect score is 10, meaning there's no evidence of early ischemic changes on plain CT scan. So you subtract 1 point from 10 for each region that is involved. So the higher the score, the better. So we also use the PC aspects. So similar to your aspect score that is used for anterior circulation, this is also a 10-point scoring system. So you subtract 1 point for each thalamus, 1 point for each cerebellar hemisphere, and 2 points for any part of your midbrain and pons. So what is the Tiki score? So we use this to assess the reperfusion after doing the mechanical thrombectomy. So what we want to achieve after mechanical thrombectomy is MTK2B, at least MTK2B to MTK3. Okay. That means there is more than 50% reperfusion of the territory of the involved artery. Okay. But you may also encounter the expanded Tiki score, which is the eTiki score, wherein it's another angiographic grading system that differentiates the 2B into 2B50, 2B67, and 2C based on the percentage of your target downstream territory. So this appears to be an independent predictor of your 90-day MRS. So let's now delve into the evolution of mechanical thrombectomy as a standard of care for LVO. Okay, so here's an overview of the evolution of mechanical thrombectomy as a standard of care for stroke. So in 1927, Antonio Monitz, or Egas Monitz, developed a technique to visualize the vessels in and around the brain. Mind you, Egas Monitz is a neurologist, okay? This is called the cerebral angiography, and almost 100 years later, this remains to be the gold standard in the diagnosis and treatment planning of vascular lesions of the brain and spine. So this discovery paved the way to neurointerventions. The attempt to treat emergent large vessel occlusion intraarterially dates back to early 1980s by giving medication intraarterially to dissolve the thrombus. In 1995, the FDA approved the use of your RTPA for acute ischemic stroke within 3 hours. And the desire to expand this small treatment window drove the development of your endovascular therapy for acute ischemic stroke. Around 2004, PROACT1 and PROACT2 trials utilized pro-urokinase for IA infusion. So this is the first stroke trial to stratify patients according to their baseline stroke severity and the first to use dichotomized MRS as primary endpoint. Despite higher recanalization rates, which is 18%, and improved patient outcome by 15% with number needed to treat of 7, and acceptable complication rates, pro-urokinase was not approved for this indication. So despite the lack of your FDA approval, the PRO Act 2 launched the era of endovascular therapy for stroke, providing fuel to companies to develop techniques to remove the clot. So in 2004, the MRCI, or your mechanical embolus removal in cerebral ischemia retriever, became the first mechanical thrombectomy device cleared for human use in the USA by the FDA. So this works by engaging the thrombus with a corkscrew distal wire and suture tip deployed from within the clot, then removing the thrombus and block to achieve the recanalization. In 2005, flexible intracranial balloon catheters were introduced. They were initially designed for vessel angioplasty and later for balloon remodeling during aneurysm coil embolization. So shortly thereafter, these balloons were used to achieve mechanical clot disruption. The introduction of your intracranial stents presented another potential tool to achieve thrombectomy. The stent-assisted recanalization for acute ischemic stroke, or your SARIS trial, in 2009 was an FDA-approved clot study of stent placement within occluded vessels that showed high recanalization rates and good functional outcome. The Penumbra, which is a second-generation clot retrieval device, was also developed on the same year. In 2010, they developed the distal access catheter, which is this one, which provides better stability during thrombectomy. And also in 2010, the results of the 3 trials, your interventional management of stroke, or your IMS3, the Synthesis and Mr. Rescue trial, failed to show benefit of endovascular therapy. Experience with using stent as clot snaring device was reported, hence the era of stent retriever was born. In 2012, 2 stent retrievers, the Solitaire and the Trevo, were introduced. A year later, the ADAP, or a direct aspiration first pass technique, became more popular. So this one uses aspiration as primary mode of recanalization. Then you may switch to stent retriever if aspiration fails or if it is inadequate. In 2013 to 2015, there are 5 trials designed to test the efficacy of these devices and techniques versus your medical therapy. So these trials are all for the anterior circulation. The Mr. Clean was the first to report that the number needed to treat was 3 to 4, to make a good outcome. So this prompted the data safety monitoring boards of the other trials to take interim analysis of their data. And all stopped their studies separately for efficacy. So from the time of the first endovascular device approval in 2004, it took more than 10 years to develop this device and finally prove its efficacy. Okay. So in 2016, the Hermes collaboration study reported that the number needed to treat by endovascular therapy to reduce disability by at least 1 level on MRS was 2.6. So the Hermes collaboration was formed to pull patient level data from the 5 trials. So the results show that endovascular thrombectomy within 12 hours led to significant reduced disability at 90 days, and that the NNT was 2.6. So this meta-analysis and its included trials helped make thrombectomy the standard of care for LVO stroke in anterior circulation. So around 2017, interventionalists further refined their mechanical thrombectomy techniques to achieve first pass effect. So these techniques include your aspiration retriever technique for stroke, or your ARTIS, and your SAVE technique, which stands for stent retriever assisted vacuum lock extraction. So the SAVE technique uses combination of various techniques to extract the clot. In 2018, additional trials like the DAWN and DEFUSE 3 studies expanded the therapeutic window for endovascular therapy, but these studies had complex criteria. So the next question to emerge was whether systemic thrombolytics provide any added benefit among patients undergoing thrombectomy, or whether thrombectomy alone was sufficient to provide revascularization in these patients. So these are the trials on direct MT versus IVT plus mechanical thrombectomy. So this showed that the SKIP trial did not show any non-inferiority, that direct mechanical thrombectomy is not inferior to mechanical thrombectomy plus IVT. Okay. Okay. So these are the trials, just recent trials on endovascular therapy for acute stroke with a large ischemic region. So the first one is the Rescue Japan limit. So the inclusion criteria include 18 years old with at least 6 of score of NHS of at least 6, baseline MRS of 0 to 1, occlusion involving your ICA or M1 at CTA or MRA, aspects 3 to 5 on CT or DWI, and randomization should be done 4.5 hours from the time of last known well. Okay, so let's skip to the results part. This showed that 74 patients and EVT had 74% recanalization rate. So it's still very high despite very large core. So they achieved TK2B or better in 86% of patients and TK3 in 43%. So this is a very high recanalization or reperfusion rate, 86%. The 90-day MRS 0 to 3 is on EVT group was 31%, comparing to your best medical group, which is 12.7%. So that's around three times higher compared to best medical management. There's no difference in symptomatic ICH rate, and there's higher rate of any ICH in EVT group, but take note that there is no difference in the rate of your 90-day mortality. So that means we can do mechanical thrombectomy for large core infarcts, but you have to tell your patients that the 90-day mortality will still be the same. Okay. Another trial for your endovascular therapy for acute ischemic stroke with large infarct is your Angel aspect. So the age include 18 to 80, baseline MRS 0 to 1, NIHS as 6 to 30, randomization within 24 hours onset, for stroke onset, CTA or MRA proven occlusion of the ICA, terminus or M1 segment, aspects 3 to 5 or more than 5 if it's more than 6 to 24 hours, with infarct volume of 70 to 100 mils, or aspects less than 3 with infarct core volume of 70 to 100 mils, or mismatch ratio of 1.2. Okay, with the interest of time, let's skip this and just proceed with this table. Okay, these are the 6 trials on EVT for AIS with large core. We can see here that all of these trials provided benefit for EVT provided benefit for large core infarct. All of these trials showed that. However, the death rate is still the same for both EVT and the best medical management. Okay. So after these large core trials, we also have your medium vessel distal occlusion trials, which are ESCAPE, the distal, and discount trials. These trials provided, this became the basis for our 2026 AHA-ASA guideline for the early management of patients with acute ischemic stroke. Okay, so let's just skip this and let's proceed with this algorithm. So who are eligible for mechanical thrombectomy? This is the first guideline which included pediatric patients, to be eligible for MT. Okay, but these are the criteria. So we can do EVT for patients with age 28 days to 5 years old, as long as there's an adequate salvageable brain tissue. And for patients 6 to 17 years old, presenting 0 to 6 hours from last known well with adequate salvageable brain tissue. Okay, for adult patients, meaning 18 years old and above, these are the criteria that should be followed. So you can just read on this algorithm. It's in your guideline. So these are the new technologies in stroke care. So in terms of aspiration, we have our new millipede. It's not available here in the Philippines, but I think in the Western countries, they're already using the millipede. And here in the Philippines, we have the Solitaire X and Trevo for the retrieval devices. And for the navigation and planning, we don't have all of this yet. For the adjunctive therapy, we have thrombolytics, alteplase, and tenecteplase here. We have neuroprotectants, but not these ones. So other countries use IV glibenclamide. Here in our country, we use citicoline, edaravone, and what is this? Cerebrolizine. Okay, so MT in current practice. So with improved technology, safer and improved mechanical thrombectomy techniques and extended time window, where are we right now? So we can see that we've already included pediatric patients, the adult patients, patients with large core infarct, patients with less favorable premorbid MRS, even patients with MRS 3 to 4 are also eligible for MT. Patients with distal middle vessel occlusion, as long as it involves the dominant side, can also be eligible for MT. So it says that we are now excluding less patients for mechanical thrombectomy. No? In contrary, pwede nating sabihin, we are including more patients for mechanical thrombectomy. So how's the status of mechanical thrombectomy in the Philippines? So we can say that mechanical thrombectomy capable centers are concentrated in Metro Manila or at least in urban areas, no? Pwede Davao or Cebu. So, but the same with comprehensive stroke centers. We can say that there's improved but still inadequate PhilHealth coverage, resulting in high out-of-pocket costs for mechanical thrombectomy patients. So there are very few neurointerventionalists here in the Philippines, both interventional neuroradiologists, endovascular neurosurgeons, or interventional neurologists. There's only one training institution for interventional neurology. It's in the medical city. They have the ladderized training program for fellowship, neurocritical and interventional neurology and vascular neurology. So to inspire you further, no, mga residents na nandito, currently there are very few interventional neurologists in the Philippines, and these are, the first one is Dr. Vince de Guzman, Dr. George Padilla, Dr. Dan Neftali Huanco, Dr. Danilo Destro, who's currently overseas, that's me, Dr. Roselyn Pamatmat, Dr. Clare Enriquez, and Dr. Kimberly Geronimo. So overall, mechanical thrombectomy future directions should aim to close the gap in the disparity in mechanical thrombectomy access and to improve the systems of care. AI-assisted imaging interpretation would lead to a more accurate and rapid triaging of patients eligible for MT. There should be expansion of comprehensive stroke centers and thrombectomy-capable centers nationwide, and committed physicians or neurologists should undergo structured simulation-based approach training and high-impact workshops that would significantly improve procedural efficacy and clinical confidence. There should be available mobile stroke units and development of telestroke systems that facilitates proper recognition, initial management, coordination, and formal transfer of your AIS patients into a mechanical thrombectomy-capable center. So healthcare, government, and policymakers should focus on stroke awareness programs and improve access to mechanical thrombectomy. So in summary, the field of interventional stroke has a remarkable history. It is characterized by technological innovation and advances. A decade after the 2015 trials that revolutionized the stroke care with MT, the field continues to evolve rapidly. So currently, mechanical thrombectomy is considered the standard of care for LV stroke, and we now have a more granular protocol guideline on AIS management. And surely, technological innovations and closing the gap in MT access will shape future outcomes. So that's the end of my slide. Thank you for listening.
Thank you, Dr. Dianne K. Ferrer. And now let us welcome our second speaker, Dr. Clare Angeli Enriquez.
So good morning. Today I will be talking about one of the most challenging situations we face in stroke intervention, and that is basilar artery occlusion. Over the past few years, new randomized trials have changed how we approach thrombectomy in these patients. But while the science is still evolving, in real life, our decisions are actually influenced not only by the evidence, but also by patient selection, cost, and the expected quality of life. So today, I will focus on how we navigate this complex decision-making strategy. Basilar artery occlusion is often described as the most lethal form of ischemic stroke. The mechanism could either be embolic, which usually presents as a top of the basilar artery syndrome, or it could be atherosclerotic thrombosis, which is a more proximal or a mid-basilar artery occlusion. Unlike anterior circulation stroke, the diagnosis is often delayed because the initial presentation may be nonspecific. It could be dizziness, gait imbalance, nausea, vomiting, double vision, all without focal neurologic symptoms. However, later on, they could progress rapidly into coma, quadriplegia, or even locked-in syndrome. If untreated, the mortality can reach up to 80 to 90%. So by the time the patients arrive, the question is often not only, can we reopen this artery, but whether doing so will meaningfully change this patient's life. It is a choice between death and severe disability. For the past few years, we have been treating these patients despite little to no evidence, but we should always ask, should we? So now let's review the timeline of the evidence that Dianne also mentioned earlier. As far back as 2015, the field of stroke treatment has dramatically changed because of the results of these 5 landmark trials. They all showed that thrombectomy dramatically improved outcomes in patients with anterior circulation large vessel occlusion. However, an important detail is often overlooked. Posterior circulation strokes were largely excluded from these trials. They specifically required occlusions of the internal carotid artery and the M1 segment of the middle cerebral artery. Even in the delayed time window trials, the DAWN and the diffuse tree trials, they also focused almost exclusively on anterior circulation LVO. So while the anterior circulation stroke treatment rapidly evolved, the patients with basilar artery occlusion remained in an evidence gap. It wasn't until in 2019 when the first randomized trial dedicated to basilar artery occlusion was published. This was the BEST trial. It was conducted in China. However, this trial was terminated early because of poor enrollment and high crossover rate to thrombectomy. Because of this, the results were neutral. Even 2 years later, the BASICS trial that was conducted in Europe also did not show a statistically significant benefit for thrombectomy in basilar artery occlusion. There was, in fact, higher rates of symptomatic ICH in the thrombectomy arm compared to the medical arm, and maybe it's because that the reason is that 80% of the patients included in the trial received thrombolysis. So patients in the medical arm actually did better than those who underwent thrombectomy. Because these early trials had both of these early trials had important limitations. One is that they had high crossover rate to thrombectomy, and second, they included patients with milder deficits. Because of this, the results of the trials were diluted. So it wasn't until in 2022 when we had the ATTENTION trial, one of the first trials to show randomized evidence that showed that thrombectomy actually improves outcomes in basilar artery occlusion. This was also done in China. They tried to focus on the early time window in patients presenting within the first 12 hours and including patients with NIHSS of more than or equal to 10. So this trial showed that thrombectomy in basilar artery occlusion is superior to medical therapy in terms of improving functional outcomes and decreasing mortality rate. Similarly, the Bauchi trial, also done in China and published that same year, but now looking at extended time windows of up to 24 hours and including patients with milder deficits with an NIHSS of as low as 6, also showed a clear benefit in thrombectomy arm in terms of functional outcome. So if you look at this timeline, thrombectomy has become the standard of care for anterior circulation stroke as far back as 2015. But it took nearly 7 more years for strong randomized evidence to emerge for posterior circulation stroke. Even then, the strength of recommendation remained weak in the guidelines that were published in the next few years. It is because of the number of limited trials, as well as both trials were published and done in China, which is an Asian population where intracranial atherosclerosis is more common. Therefore, the generalizability of the results were in question. Another important nuance in posterior circulation trials is the definition of a good outcome. So in the anterior circulation stroke trials that were presented by Dr. Ferrer earlier, the definition of a good outcome is an MRS of 0 to 2. But in basilar artery occlusion trials, they defined a favorable outcome as an MRS of 0 to 3. So this tells us that patients with moderate disability may still be considered a meaningful recovery if you compare it with death or locked-in syndrome. So after the publication of these trials, a series of meta-analysis including observational data, finally in 2026, the American Heart Association and American Stroke Association now strongly recommends thrombectomy for basilar artery occlusion as long as the following criteria are met. The NIHSS should be at least more than or equal to 10. They should have a pre-stroke MRS of 0 to 1, good baseline functional function. They should have evidence of mild ischemic injury on imaging. This is typically using PC aspects. I will discuss this later on. And they should be treated within 24 hours of symptom onset. If the NIHSS lies between 6 to 9, the level of evidence and the classification of recommendation is a bit weak. Okay? The guideline also recognizes these situations where evidence still remains limited. These are patients with very severe stroke, pre-stroke disability, patients with extensive brainstem infarction, those with lower PC aspect scores, occlusion of the posterior cerebral artery or the vertebral artery, or patients with low NIHSS or mild symptoms. In these cases, the decision-making should be individualized. So now that we have reviewed the evidence, the most important question becomes, who are the patients who would truly benefit from thrombectomy in basilar artery occlusion? Because in posterior circulation stroke, patient selection is everything. Let us start with the clinical features. So most of the randomized trials included patients with NIHSS of more than or equal to 6. They included patients with significant and severe neurologic deficits, even patients in coma or who are quadriplegic. So paradoxically, unlike in anterior circulation stroke, very severe presentation is not a contraindication. It is actually the norm. But beyond the acute presentation, we also look at the patient's baseline status, and there are 2 key factors. First would be the pre-stroke functional status, because we know that patients with MRS of 0 to 1 before the stroke are much more likely to benefit from the procedure because they have a higher or better chance of returning to their independence. Second would be age. While age alone should not exclude patients, older patients tend to have a less physiologic reserve and higher risk of poor outcomes. So clinical context actually matters. On the other hand, let's move to imaging, which is also a critical component. We need to determine how much of the brainstem is already infarcted, and one of the most useful tools would be the PC aspects. A score of 6 or higher suggests that we have a limited infarct core, we have a potentially salvageable brainstem tissue, and this is the key inclusion criteria in the positive trials, Bauchi and Attention. Because once the brainstem is already infarcted, the outcomes are often poor regardless of successful recanalization. Another thing to consider would be the collateral status, and it's via the posterior communicating artery. I'll show you pictures later on. And we also take a look at perfusion imaging if this is available, because CT perfusion and MRI DWI flare mismatch help us identify patients with salvageable tissue despite delayed presentation. We have to remember that in posterior circulation stroke, they have a longer therapeutic window compared to anterior circulation stroke. So when we put all this together, patient selection becomes a balance of clinical severity, baseline functional status, infarct burden, collateral circulation, and tissue viability. So briefly, I think Dr. Ferrer also mentioned this earlier. This is the PC aspect score. It is derived from the anterior circulation aspects, but now it evaluates early ischemic changes in the posterior circulation. You can do it with either a CT or an MRI. The score starts with 10, right? And you can use this mnemonic to remember. Time and mortal brain decide posterior circulation outcomes. So those with lateral structures like thalamus, the cerebellum, and occipital lobe gets 1 side on each side, but the pons and midbrain, the brainstem structure gets 2 points automatically, even if it's just 1 side that is affected. So a lower PC aspect score tells us that there's a larger infarct burden, particularly in the brainstem. And this is important because patients with low scores will have extensive infarction and they would tend to have poor outcomes even if recanalization is successful. Another important and underappreciated factor in basilar artery occlusion would be the presence of the posterior communicating artery collaterals. These vessels connect the anterior circulation to the posterior circulation, allowing blood from the internal carotid artery to supply the PCAs, the posterior cerebral arteries, if the basilar artery is occluded. So you can see in this picture, we go up from the verts, and then there's non-opacification of the basilar artery. And then you see the PCAs filling from the robust PCOMs on both sides. So why does this matter? Because in basilar artery occlusion, time alone does not determine tissue viability. The collateral circulation does. So patients with robust PCOM collaterals can maintain perfusion to the brainstem and the occipital lobes, effectively buying time and slowing infarct progression. In contrast, patients with poor or absent collaterals rapidly develop brainstem infarction. It becomes more extensive even in a short window of time. So this has direct implications for thrombectomy because patients with good PCOM collaterals are more likely to have higher PC aspect score, a smaller infarct core, and ultimately they achieve better functional outcomes after reperfusion. So even with thrombectomy, poor functional outcomes remain common in basilar artery occlusion. In large analysis of the positive trials, about 45% of patients achieve an MRS of 0 to 3, but mortality is still high. It still approaches around 30 to 40% at 90 days. More importantly, when you look at the overall picture, more than half of the patients either die or survive with significant disability. So while thrombectomy actually really does improve outcomes, functional independence is not always guaranteed. It is not a uniformly successful intervention. It is a one with a wide spectrum of outcomes. Even if we look at the long-term outcomes, the picture becomes even more complex. It is true that in this 3-year follow-up of the attention trial, the benefit persisted up to 3 years with lower proportion of mortality and a higher proportion of good functional outcome in the thrombectomy arm compared to the medical arm. But you have to look that the overall mortality increased over time, and the proportion of patients with good outcome also decreased slightly over time. This tells us the long-term consequences of the severe brainstem injury, the complications of disability. These patients can develop aspiration pneumonia, infected bed sores, deep venous thrombosis, or pulmonary embolisms, or the result of their comorbid conditions that led them to develop basilar artery occlusion. Most of these patients would have uncontrolled diabetes, uncontrolled hypertension, that can also lead into other ischemic events. So up to this point, we have been discussing thrombectomy from purely clinical and evidence-based perspective. But in real-world practice, especially here in our country, there is another critical factor, and that is cost. A thrombectomy procedure can cost anywhere from 800,000 to 1 million pesos, excluding hospitalization costs. And for many of our patients, this is out of pocket. This means that a single decision in the emergency room can lead to a catastrophic healthcare expenditure for the entire family. So the decision to proceed with thrombectomy, it's not just a medical decision. It becomes a family decision made under extreme emotional and financial pressure that has to be made within minutes to hours after symptom presentation. And we have to be honest about what we are offering, because in some cases, the reality is, yes, we may save the patient, but the patient may remain severely disabled. So how do we approach this? When I discuss these cases with families, I try to frame the decision around a few key considerations. So first, we ask about the patient's pre-stroke function. Was the patient independent, active, and working before the stroke happened? Second, we ask about family expectations. What level of disability would be acceptable to them? They are the ones who know the patients better. Is the patient a fighter? Is the patient okay to be bedridden as long as they are alive? Only the family can answer that. Third, I explain to them the infarct burden, how much of the brainstem is already affected, how much is there left for us to save. Fourth, we ask about the patient's age and comorbidities, which would definitely influence the recovery potential. And finally, something that we cannot ignore, financial burden. This is very variable from one patient to another. One family would have to sell all their farm animals, would have to borrow loan or from a bank that they could not pay, but others, they would barely feel 1 million pesos, so they would do everything even if it's just like a 1% chance to improvement. So it's very, very variable. So to sum up my lecture, let's finish with these two cases. First, we have a 58-year-old man who presented with sudden onset coma and quadriparesis. His NIHSS is 28. Imaging showed basilar artery occlusion. More importantly, on the CT scan, the PC aspects is 8. You could just see early ischemic changes here in the left cerebellum and the left occipital lobe. And if we look at the CT angiogram, there's good PCOM collateral. So these are the verts, and then you see non-opacification of the basilar artery there. And then you see the PCAs filling from the bilateral PCOMs, okay? So would you proceed with thrombectomy? Yes? I think most of us would say yes, no? Because this is a classic example where clinical severity looks bad, but the brain is still salvageable. This is a patient where thrombectomy could be truly life-saving and function-restoring. So now let's look at a different scenario. A 76-year-old woman, wake-up stroke, around 10 to 12 hours from the last known well time, also came in comatose with an NIHSS of 32. Imaging shows basilar artery occlusion, but on MRI, there's already bilateral pontine and midbrain infarction. Although the PC aspects is 6, technically, this patient still meets the criteria to be eligible for thrombectomy based on the HAASA guidelines. But now the question becomes much more difficult. Would you still proceed with thrombectomy? Depends, no? Technically, yes, we can open the artery, but biologically, the brainstem may already be irreversibly injured. And this is where everything we discussed comes together. We look at imaging, we look at the collaterals. In this case, there's no PCOM. The patient's age is 76. We explain the expected outcome to the family. In our setting, the cost, of course, because in this patient, even if we are successful in opening the artery, the most likely outcome may be severe disability or even death. And this is where the real challenge is. It's not about performing the procedure or opening up the artery, but it is in deciding when should we stop and think whether we should still perform it or not. So in summary, we have seen that thrombectomy has indeed transformed the management of basilar artery occlusion. Now we have strong evidence that shows that it actually improves outcomes and reduces mortality. But we have to remember that posterior circulation stroke remains fundamentally different. Outcomes are very variable, and even with successful recanalization, some patients are left with severe disability. So the challenge is actually no longer technical. It's no longer about how fast or how well we can open the blood vessel, but the real challenge is choosing the right patients. Again, this requires integrating clinical severity, imaging findings, collateral status, and the expected quality of life. And in our setting, we must also consider the cost and the impact on the family. So ultimately, cracking the posterior circulations code is not just about reperfusion, but it is about judgment. It is about communication, and it is about making decisions that align with what actually truly matters to the patient. And only the family members know that. Because in the end, success is not just about opening the artery, it is restoring a life worth living. So thank you very much.
Thank you, Dr. Clare Angeli Enriquez. And now, let us welcome our third speaker, Dr. Roselyn Pamatmat.
So, good morning, everyone. So, it's truly a pleasure to be here. Thank you, PAVIN. And I'm happy to be sharing the stage with my fellow interventional neurologists. So, over the course of the last lectures, we've heard about the promising future of mechanical thrombectomy, how it is performed, and the strong body of evidence of mechanical thrombectomy. And of course, the potential complications. Building on that, I'll be focusing on what happens beyond the procedure itself. So particularly, what is the role of hemodynamics and physiology in determining the patient's outcomes? So these are my objectives. So, reperfusion does not always equate to good recovery. We have achieved faster workflows already abroad. Well, here we still have a lot of work to do, but we have better devices, and we have higher rates of reperfusion of around 70 to 80%. But despite all of this, only about 40 to maybe half of our patients actually regain independence. So the question is why? What happens after we open the vessel? And how can we improve the outcomes of our patients? So this is where neuroprotection comes in. But before discussing neuroprotection, let's briefly discuss the ischemia reperfusion injury cascade. So I hope you can see the slide. So ischemia leads to energy failure, glutamate excitotoxicity, and calcium overload, which results in mitochondrial dysfunction. And this is followed by inflammation and blood-brain barrier disruption. Now, when we open that vessel and when we reperfuse the brain, it is not always purely beneficial. So it can act as a secondary injury. The sudden return of oxygen triggers a burst of oxidative stress, which further damages the mitochondria and causes inflammation and blood-brain barrier breakdown. So this is where we call it futile thrombectomy. Because even if we macrovascularly open the vessel, there is a no reflow phenomenon in the capillary level. So the outcome of the patient is still not good. So because of this complex injury cascade, neuroprotection aims to preserve the vulnerable brain. And it can be divided into two, pharmacologic and non-pharmacologic. So in pharmacologic approaches, it targets specific areas in that ischemic reperfusion cascade injury. In contrast, physiologic optimization directly influences the cerebral blood flow. And in essence, hemodynamics can be the key determinants of penumbral survival and or infarct progression. So these agents target key pathways in the ischemia reperfusion cascade. So it targets the inflammation, oxidative stress, excitotoxicity, and microvascular dysfunction. And then we have these pharmacologic agents, the nerenatide, uric acid, imatinib, and otaplimastat. And actually, they show promising results. At present, pharmacologic neuroprotection remains investigational rather than practice-changing. And these are the non-pharmacologic strategies. Therapeutic hypothermia, we know of this intervention already, but this has limited clinical feasibility in acute stroke. Remote ischemic conditioning and normobaric oxygen therapy have also been studied and actually show promising results as well. but these strategies remain investigational and are not routinely incorporated in EVT practice. So, we shift our focus to maintaining optimal neurophysiologic targets. So what are these? We target normoxia, normocapnia, because we know that carbon dioxide directly influences the cerebral vasoreactivity and blood flow. We also target normoglycemia, because hyperglycemia is consistently associated with larger infarct volumes and worse outcomes. And finally, normothermia. As fever increases, metabolic demand increases and amplifies inflammation. While these targets may sound or may seem very basic for us, even small deviations can significantly worsen outcomes. Among all these physiologic variables, BP is the most dynamic and arguably the most important during thrombectomy. So this brings us to a fundamental concept in acute stroke physiology, that in ischemic brain tissue, cerebral autoregulation is impaired. As a result, the cerebral blood flow becomes directly dependent on systemic blood pressure. This means that systemic hemodynamics are not simply supportive, they actively determine the adequacy of collateral perfusion, which is very important for the penumbra to survive. So in these succeeding slides, we will be briefly discussing the following. What is a normal autoregulation curve? I'm sure Dr. Flores has already discussed this. What happens when there's a stroke? And what's the role of collateral circulation in determining the outcomes of our patients? So briefly, under normal conditions, cerebral blood flow remains relatively constant across a wide range of systemic BPs because the brain can autoregulate. On this graph, this plateau, where changes in blood pressure do not significantly affect cerebral blood flow. But what happens when there's a stroke? Autoregulation malfunctions, and the cerebral blood flow becomes BP dependent. So instead of a plateau, the curve becomes linear, meaning the cerebral blood flow now directly follows systemic blood pressure. So when BP drops, cerebral blood flow also drops proportionally. And because the penumbra is already a critically hypoperfused part of the brain, even small decreases can push it beyond the threshold into irreversible infarction. So now let's turn to penumbra and the role of collateral circulation. So penumbra represents, again, a viable but critically hypoperfused area. So its survival depends on a lot of factors, and one of which is the leptomeningeal collaterals. And these leptomeningeal collaterals provides alternative pathways of perfusion. Importantly, collateral flow is, again, pressure dependent. So this figure shows how collateral circulation influences stroke outcome. On the left is the normal circulation. In the middle, you can see an MCA occlusion, but this patient has poor collaterals. So because there are poor collaterals, the penumbra rapidly progressed into infarct. Looking at the image on the right, this patient has same MCA occlusion, but with good collaterals, the penumbra actually survives. So, outcome depends not just on the occlusion, but on collateral quality. So I'll just show some images. This is a patient with a left M1 occlusion, and on late arterial and early venous phase, we couldn't see any leptomeningeal collaterals. Essentially, this patient has poor collateral status. Typically, these patients, once we intervene, even if we open the vessel, they might have a bad functional outcome. But look at this one. This is also a left M1 occlusion, but we see robust collateral supply, not just from the anterior cerebral artery, but also from the posterior cerebral artery. So, once we open this vessel, and if this patient is successfully recanalized, we could possibly see a better outcome for this patient. So now let's talk about the BP targets in thrombectomy. So a practical way to approach this is to divide it into 3 phases. First is pre-recanalization. So the goal here is to sustain the collateral. Then during thrombectomy, or what we call intra-procedural, the focus shifts to maintaining hemodynamic stability. But after recanalization, the goal becomes different. After successful recanalization, the physiology changes and the goal differs. So the goal becomes preventing reperfusion injury and hemorrhagic transformation. So rather than applying a single BP target, management should be dynamic and adapted to each phase. So remember this. So, pre-EVT BP target. So before the thrombectomy, again, the autoregulation is impaired, and reduced BP can decrease collateral flow and accelerate infarct progression. Actually, the latest guidance, the 2026 guidelines, would say that the BP target should be at least 185, below 185 over 110. But the large clinical trial on mechanical thrombectomy actually follows the BP target of less than 180 over 105. So, intraprocedurally, during thrombectomy, the primary target is to maintain adequate cerebral perfusion. And observational data suggests that maintaining systolic BP in the range of 140 to 160 can help support the collateral circulation. From a physiologic standpoint, maintaining a MAP of more than 70 can sustain cerebral perfusion. However, more importantly, the avoidance of hypotension and rapid fluctuations are more important. So one of the most consistent findings in EVT is the harmful effect of hypotension. A drop in MAP of more than 40% from baseline, or a BP of less than 140 during occlusion is associated with worse outcomes and infarct growths. Post-recanalization. What happens once we open the vessel occluded? So the underlying physiology changes. Note that even if we open the vessel, the cerebral autoregulation does not immediately recover. So the brain remains vulnerable despite restoration of blood flow. The reperfused tissue becomes relatively hyperemic and structurally fragile. And high BP can exacerbate blood-brain barrier disruption, leading to cerebral edema and hemorrhagic transformation. Now, the 2026 guidelines said these BP targets after thrombectomy. The current guidelines recommend keeping BP at or below 180 over 105 after endovascular thrombectomy. And they also caution the intensive BP lowering to less than 140. But in practice, post-thrombectomy BP should still be individualized. Too low, we may worsen the hypoperfusion. Too high, we may increase the hemorrhagic transformation. So the goal is not one rigid number, but the BP range matched to the patient's reperfusion status and risk profile. So these are what observational and cohort studies would say. We lower the BP once the patient is completely recanalized, typically targeting SBP of around 140s. Maybe that's the sweet spot. this is especially for patients with complete recanalization. And we can target a little higher BP for incompletely recanalized vessel. Take note that randomized trials show that intensive BP lowering to around 120s or 130s do not improve outcomes. So the rule is lower BP after the perfusion, but avoid overcorrection. Another important concept is variability. So higher BP has been independently associated with worse outcomes. So we target smooth, stable BP control. And bringing this together, we can see from this table the BP targets. So again, for the post-EVT, this should be individualized. For completely recanalized one, around 140s. For a partially recanalized one, we can target the BP at a little higher level. At the same time, anesthesia plays an important role. General anesthesia may predispose to hypotension, but if you ask me as an interventionalist, I would have been more comfortable doing the case under GA. Because under conscious sedation, most of this large vessel occlusion are restless. So it's difficult to maneuver the catheter. But anyways, for as long as the targets, the hemodynamic targets are achieved, that is the more important thing. Because the randomized trials show no clear difference in outcomes. So what matters is not the technique, but how well blood pressure and physiology are controlled. So these are the common pitfalls: overcorrection of BP pre-procedure, hypotension during induction, and ignoring BP variability during the procedure. So as neurologists, interventionalists, neurocritical specialists who will manage these cases, we must be focused on these possible events to prevent further damage. So let's conclude this with a few cases, my actual cases. So let me share this first case. This is a preventable physiology-related poor outcome. So this is a 63-year-old male, hypertensive, smoker, who came in for right-sided weakness, aphasia, decreased sensorium, 6 hours post-ictus, with an NIHSS of 25. So the patient was brought to cath lab after diagnostics and talking to the family for thrombectomy, and was thankfully successful. But notably, BP was aggressively lowered down prior to thrombectomy at the ER, prior to referral. And during the procedure, the SBPs intermittently dropped to around 110s. These hypotensive episodes likely reduced the perfusion to the penumbra, and that may have progressed to infarction. And despite successful recanalization, the patient had massive edema, stayed in the hospital for 3 weeks, and due to other medical complications, went home bedbound. But we also have great cases. This is a 39-year-old male who came for right-sided weakness, drowsiness, aphasia at 6 hours post-ictus. NIHSS was 30. And an MRI did show infarction of the left MCA. MRA was requested. We can see an occluded left MCA. Hence, we proceeded with mechanical thrombectomy. And thankfully, this was recanalized well, and the patient improved from NIHSS 30 to 3 for mild slurring of speech and mild weakness. But we have to take note that BPs were maintained at permissive levels pre-recanalization. There were no intraprocedural low BPs, stable hemodynamics throughout, and no BP spikes post-recanalization. So from the last 2 cases, we see same occlusion, different physiology, different outcome. And I hope we all learn from this. So thrombectomy does not end with recanalization alone. The brain remains vulnerable. What happens before, during, and after reperfusion, especially hemodynamics, determines the tissue survival. And take note that these are within our control. And these require coordinated multidisciplinary care with neuro, interventionalists, anesthesiologists, critical care specialists, nursing staff, rehab. Because even if we open the vessel, physiology, teamwork, and of course, correct patient selection determine the outcome of the patient. So what we control still matters the most. Thank you very much.
So thank you very much to our speakers for their meaningful and comprehensive lecture. So your expertise have provided us with very valuable perspectives on interventional stroke medicine. So we have seen how mechanical thrombectomy has changed throughout the years, both in indication, in scope, and even in technique. So mechanical thrombectomy is not something that's very abstract. It's not something that we wish we have, because it is something that is currently available and we have people to do it. So now we open the floor for questions. Again, you may scan the QR code flashed on the screens, or approach the microphones to ask your questions. Can I have the questions, please? Okay, we'll ask. Hello. Ayan, okay. So, while we wait for the questions, I'll ask all three speakers. Thank you. So while we wait for the questions to be flashed, I'll ask all three speakers, what is your advice to our residents that are watching here if they want to go into our field? So I guess we'll start with Dianne.
My advice would be to be exposed early into interventional neurology. So what I did, my personal experience was, I had my elective early on my third year of residency in Indonesia, and that mentor actually helped me to go into my fellowship training. Also, you have to write a lot of papers, research papers on interventional neurology or stroke. No, this will be the first step that you should do actually, and you have to collaborate, no, with your peers and fellow vascular neurologists also. That's it.
Thank you. Clare?
Hi, so yes, we encourage our residents who are interested in pursuing stroke and interventional neurology to reach out to us so we can advise you. But basically, just like what Dianne said, start early. So during residency, you develop your portfolio, work on research focusing on stroke and intervention if you can. Do not ever, it's a bit intimidating at first, looking for interventional neurology fellowship, but you would never know unless you tried. So most of the international fellowships for interventional neuro would require stroke fellowship, and think about doing your stroke fellowship abroad as well if you wish better chances into getting into interventional neurology fellowship abroad. So I think that's it. We're always here. You can always reach out to us, and we can guide you in applying.
All right, thank you. RP?
So hello. I think it's better to have a mentor. So look for a mentor who will guide you. Because, pursuing this specialty is really intimidating, and it's very hard to find fellowship trainings and all. So someone to guide you and give you advice on what to do and refer you to his network of doctors can help you if you really want to pursue the fellowship. Also, first you have to ask whether you really like this or not, because this is a rather stressful specialty. Yeah.
Thank you. So yes, it's really a very challenging and stressful subspecialty in neurology. And it used to be very difficult to find training programs who will accept neurologists to train. But the times are changing now and there are more and more programs accepting neurologists. Okay, so questions from the floor. What are your thoughts on mechanical thrombectomy in patients with LVO but with low NAHSS? So I guess, Dianne?
Well, patients presenting with LVO but with low NIHSS, no treatment with MT is still very controversial. The previous guideline tells us that the class of recommendation still 2B, that means weak recommendation, no. But if personally, I would still do it if the patient is has rapidly declining neurological status, or for example, some referrals kasi they would use the aspects even for posterior circulation. Dapat PC aspects yung ginamit. So sometimes they would have better aspect score, tapos lower NIHSS, sinasabi nila. Ano pa? Patients with low NIHSS but is still disabling for patients. No, I would still treat it. Yeah.
All right, thank you. So that's right. If it's disabling and deteriorating, then we might go ahead and do the thrombectomy even if the NHSS initial is low. Next question, I think this was answered in one of the talks by Clare. If we were to appraise patients for mechanical thrombectomy, how much is the usual cost of the procedure?
Yeah, so it actually depends on the technique. Usually, if we try, personally, I would try to do aspiration first because the stent retriever, they cost around 250,000 pesos. So if you are able to remove the clot just with aspiration, you can quote it at around 600,000 pesos. But if we are to use a stent retriever, it could go up to 800,000 pesos. And that's very variable because some of the hospitals would mark up more. Some of the hospitals would accept direct purchase or direct payment to the suppliers, then that makes it cheaper. So I think.
Yes, so it's really difficult to say whether you'll use just aspiration alone or stent retriever alone or even both. Actually, when you're in the field, you plan for, you're ready with whatever option you have, and then we do our best to remove that clot. So the cost will go about that same range. No, I think we all have the same ranges that we quote our patients with. Okay, so anyone can answer. What is the oldest patient you have performed on a thrombectomy on, and what was the outcome? Thank you for the excellent discussion.
I would answer this coming from my fellowship program, which is Canada, where everything is actually paid for by the government. We have treated patients as old as 96 years old. So as long as they have good baseline function, and yeah, they indeed recovered really well, like they recovered as if nothing happened. But we've also done thrombectomy for 95-year-old patients with poor baseline, and they also did not make it. But their cost was not an issue. No, the family would not pay for anything, so they have been working hard to pay for their taxes all throughout their lifetime. So if they get this 1% chance to live, then they would take it because they don't have to pay for anything. So the situation is different here back home.
Yeah, okay. We have a question from the floor. Sige, go ahead, Doc.
Congratulations for the excellent lectures for the three of you. No? Okay. Ang question ko is, kailangan bang may beauty para papasok? Thrombectomy. Joke lang yon, okay? Kailangan bang beautiful ka para pumasok? No, joke lang yun. Okay, my question is, marami kasi tayo nakikitang abnormalities. For example, would be the posterior fetal circulation, no? Fetal origin circulation. Lately, we see a lot of this, no? Okay, so my question is, would this type of abnormalities affect selection and prognosis with
So in terms of
thrombectomy?
posterior circulation stroke, doctor, so maybe you're asking about fetal PCAs,
Yes, fetal
where
PCA.
yeah, the PCA is arising from the anterior circulation. So as long as we have an access to the clot, like we're able to get the clot into the top of the basilar from the vertebral, we can take out the clot. But let's say the vertebral arteries, for some reason, are the one side is hypoplastic, the other side is occluded, then for posterior circulation, you have then you don't have an access to the clot, and you can do the procedure. I'm not sure.
Same po, no? For as long as we have the access, there's no contraindication to do.
How about prognosis?
So far, there are not much difference in terms of the outcome of patient. For as long as there is successful recanalization and there are no hemodynamic compromise during the procedure.
Thank you.
Ayan. Thank you, Dr. Joyce. Go ahead po.
Yes, good morning. Congratulations. Anyone can answer. What's your take on repeated like aspiration or retrieving the clot? Because I had a patient, like a 56-year-old female. Well, she happened to have cardiomyopathy also. But she was within the window period, and we recommended mechanical thrombectomy. However, it was a right ICA occlusion. So initially, there were several clots kasi that were retrieved, but hindi kasi kinaya ng isang pasok lang. So any comment on that? Because eventually, upon repeated aspiration or retrieving, nag-recanalize and successful. However, nag-hemorrhagic conversion and the patient succumbed. So, any take on that? Thank you. Anyone can answer.
Nag-recanalize pero nagkaroon ng symptomatic ICH. A reperfusion injury. Right. Well, depende kasi kung gaano karami yung passes, no? The risk increases as kapag mas marami na yung passes, especially if you're using stent retriever. But if it's ICA, usually they just do aspiration, no, for ICA, na cervical ICA. For terminal ICA, we can use stent retriever also, and you have to evaluate ano ba talaga yung etiology ng occlusion. Kasi sometimes we do multiple passes if it's intracranial artery sclerosis, stenosis. So that would increase the risk of perforation, no, and worse outcome actually for patients, or lower rate of recanalization. So you can do emergent stenting for these patients instead of multiple passes. Okay.
Thank you, Doc. So, for my side, it depends on what the cause is. So sometimes patients have hypercoagulable state and they really have extensive clot burden. So if they are still within the time window, like early, and their chances for your reperfusion injury is low, then I would do everything I can to open up the vessel, as much as maybe 5 passes. And if it's my last pass, sometimes if there's a risk, like tira-tirang tenecteplase or alteplase from the thrombolysis, I also inject it intraarterially while the stent is open to soften the clot. And then maybe that's my last pass. If this does not work, I ask my assistants to tie my hands behind me so I don't go back for the clot again. So you have to also learn when to stop, because if you keep on trying and trying, you're doing more harm for the patient. So it's every time you open up a stent and pull it out, it causes trauma into the blood vessel. So the more passes you do, the higher risk for perforation, for other complications.
Thank you. Sir, you may go ahead.
Thank you very much. First of all, I would like to congratulate you guys, the girl power. Well, I think this is not really a question, rather an editorial. What I notice is that, you know, what I wanted to is that all people doing thrombectomy should know something about the brain. Right?
Yes.
What I'm saying is, unfortunately, hindi ko sana magalit sa akin yung mga radiologists, ano? They're the ones controlling. See that? What I've noticed is that a interventional neurologist would schedule a patient in radiology for interventional radiology. But, okay, sige, dalhin mo yung pasyente mo rito, pero wala kang technician. Because we're the ones handling the technicians. Eh kaya wala kayong control doon sa, sa radiology. Now, the point is, can we do something about this? That those people in interventional radiology should undergo something about, or know something about neurology. They don't even know whether the patient stroke out during the procedure. So I really would like that probably through our association, that we require I don't know if that's too much, those people in radiology doing interventional neurology should have something to learn from the neurology standpoint. I think that's quite important. Kasi, you know, I don't want my patient to be poked by somebody who doesn't know about neurology. So, through our association, let's try to do that, you know, and see what we could do to improve. That would improve the training, and that would improve, of course, the outcome of our patients, the service that we give to the patient. So thank you, Dan.
Sir, thank you. Thank you for that comment. Any comments from the floor? From the panel?
Thank you, doctor, for that comment. I actually came from a program where we have neurosurgeons, radiology, and neurologists doing interventions all together. Like, it's a very diplomatic program. So what I've seen and what I think is helpful is for the stroke neurologist to be present also during the procedure. Because sometimes the neurosurgeon would ask the neurologist if, let's say, there's a residual clot, do you think it's safe if I should go again? Like, should I do another pass to try to open this? Do you think I should stop? Do you think it's safe to give intraarterial thrombolysis in this patient? And the stroke neurologist helps my neurosurgeon and radiology bosses to answer those questions. So I think it would be helpful for us to be present, or for the neurologist to be present during the procedure. Yes, doc. Ideal.
All right, that's right, sir. Yes, sir, you have one more question.
Just an additional comment, no? For how many years, no? Ang nakikita natin, ang model natin should be the cardiologist, diba? They've been doing this for how many years? 40 years, 30 years. Ahead sila sa atin. They've been doing the PCI. Bakit ang neurologist ngayon pa lang mag-uumpisa actually? So I think that's a challenge, no? That's a challenge. Yung kanilang sa PhilHealth nila, nakapackage na yan eh. So I think yun ang isang way na kailangan para makita natin, bawasan natin yung cost. No? Ang isa is, kailangan dumami kayo. Okay? So how do we do this? Probably, mag-train, pwede ba mag-collaborate kayo and train? Mag-ano kayo, para hindi na tayo pupunta ng abroad. Diba? Yun ang problem eh. And I'm offering BGH. You can, probably, kung gusto nyo, maging affiliate kayo doon, and then we will form a program for, and of course, it could be a collaboration with other hospitals. No? Okay. So, kasi ito nga, 30 years nang naiwan tayo eh. So that's a challenge for everybody. Thank you.
Thank you. Thank you for that comment, sir. Yes, Dr. Navarro.
They should keep their eggs. Because they're all exposed to radiology, right? Their eggs. Siguro another challenge for PAVIN is we should make representation with Medicare. para bang yung package ng when somebody will develop a myocardial infarct, meron kagad Medicare cost na 500,000. Now, once you're labeled MI protocol or something, then the PhilHealth can now shoulder almost 500,000. So, again, siguro through our association, we can make representation with PhilHealth. No? And we can do that. Sabi nga ni John, magparami lang kayo ng konti, kaya na natin yan. No? There's always strength sa numbers.
Thank you, sir. Okay. Any more questions from the floor? All right, so we have a few more questions. We'll just answer a few more. Anyone can answer, what is the evidence of intra-arterial thrombolysis in patients who are already ineligible for mechanical thrombectomy?
Personally, I would only consider intraarterial thrombolysis if, let's say, this patient is already in the cath lab, because on CT angiogram, they have a large vessel occlusion. Let's say it's M1. And then this patient received IV tenecteplase. Because tenecteplase is strong, it can now open large vessel occlusion. But on angio, it's not M1 anymore, but it's a distal M2 that is no longer a target for thrombectomy. And then maybe I still have like a leftover tenecteplase or alteplase. That's the only time I would consider intraarterial thrombolysis. But I haven't really taken someone into the cath lab just because they have an M2 occlusion or a distal occlusion that I cannot reach with thrombectomy. So that's my personal experience. And of course, before giving the thrombolysis, you have to think about the patient's risk for hemorrhage as well.
Like for M3, I mean, now distal trials did not show any good evidence for thrombectomy. But there were some cases wherein there were M3, but very eloquent portion of very eloquent vessel. So sometimes we also try to intra-arterially thrombolyze that patient. But it's not guideline-based. It's more of a case-to-case basis. If we think this might help the patient and we cannot reach that thrombus through the available stents that we have, then we can at least try intraarterial thrombolysis for very distal occlusions.
Okay, thank you. So actually, there are a lot more questions sent through the QR code, but if your question wasn't read, please, you may approach any of our speakers after the talk. So baka next time, mas mahaba yung time ng interventional neurology. So, okay, so again, we extend our heartfelt thanks to our speakers. This dialogue has enriched our knowledge and underscored the importance of innovation and precision in stroke treatments. So as we conclude this session, may the insights we've gained today inspire continuous progress in interventional stroke medicine. We also have hope that we have inspired our residents here to go into our exciting field. You may approach any of us for further directions. So on behalf of the organizing committee, I thank our speakers once again and all of you for joining us. We wish you a pleasant day ahead as we continue with the rest of our convention. Thank you very much.
Thank you to our speakers, Dr. Dianne K. Ferrer, Dr. Clare Angeli Enriquez, and Dr. Roselyn Pamatmat, and to our moderator, Dr. Dan Neftali Huangco.